Thank you, Dr. Ndagurwa. It's always difficult to speak after my boss, but I will try to do justice. So I'm going to talk about one of the risks which Dr. Verenga was saying we need to screen. So I'm going to talk about aneuploid screening. But at this point in time, it's at a higher level. It's called an advancing aneuploid screening. It's no longer an ordinary aneuploid screening. You all know that there is now AI, and also there is some advances in molecular genetics. So we are trying to see a way of fitting these robots or this AI thing into our scanning so that we can make our scans top-notch. So I will try to balance. We all know that in life, what we want versus reality, there's always a conflict. Even if you have to look at your partner, that's not the partner you were willing to have, but somehow, that's the reality of life. So what I'm going to do today is I'm going to balance what is the best practice, but also put into perspective our Zim situation. We all know our situation, but we try to put a bridge to see what will be best. So at the end of my talk, if a pregnant woman walks in, there are no two ways. You know the optimal test to do for aneuploid screening. So this is my talk which I'm going to do today. So why am I doing this talk? From our fetal medicine unit, we've noted a number of challenges. Number one, we are getting rising maternal age. We all know academic careers, we are pursuing academic careers. So these women are coming to us more than 35 years old. And you know the risk of trisomies goes quite high up in this age group, especially for urban women here in Bulawayo or even in Harare. Then we also noticed a rise in late bookers. The women who book late, most of them, they book in the second trimester. Of course, we encourage them to book early, but most of them book in the second trimester. We also note that there's still limitation to access to invasive testing. So these tests are the ones which we do for diagnosis. I think the guys from Harare can testify. It's only Pari, Harare Hospital, and probably in private, where we are offering invasive testing. Which means there should be something which should be done so that we don't go to invasive testing. Again, we have noted some rise in the trisomies. All those babies who are born perinatal mortality, all those high numbers of perinatal mortality, we have noted that others are due to aneuploidy. So there's no way you can come out of here without knowing what to do about aneuploidy. Now, for the sake of clarity, when we talk of aneuploidy, we are just talking of numerical problem. Where is my camera? Maybe it's not. Oh, it's there. Alright, it's not moving the way I want. It's okay, I'll come to the bed. So it's a numerical problem. We all know that we should have 46 chromosomes. But look here, for the Down syndrome, there's an extra pair of chromosomes. So this is what we note when we have trisomy. So it can be there at 21, it can be there at 18, it can be there at 30, or at times on your sex chromosome, you might miss one of your chromosomes, let's say with a 10, or you might have an extra chromosome, those supermen, that still falls under aneuploidy. So it's a numerical problem when we talk of aneuploidy. Now, let's go to our data. So, is this aneuploidy, which you said can be trisomy 21, 18, 13, or even the sex chromosome? The commonest is Downs. That's why you see all of my talk, I'll mainly focus on Downs, because it is the commonest
which we see there. The other ones are rare. If you miss these rare things, we can let you go even if you're in SRMO. But if you miss downs, for sure we'll give you another year, because this is the commonest problem in our local setup. Now, so what are the pillars for screening aneuploidy? Even when you are in Mutare, even when you are in Harare or Bulawayo. So this is our pillar. Number one, we got a baseline risk, which Dr. Wering was saying, maternal age. With maternal age alone, we already have a risk. Which means after talking to a woman, there should be a risk at the back of your mind. Even without tests, with the maternal age alone, you can get a risk. Of course, you got your serum markers, and we got an ultrasound scan. But the bottom line is to say, of all these screening tools, the combination is the best. I think even nature can testify that when things are combined, they offer a best solution. So it's the same way when we do screening. So we need to combine everything. We don't rely on one method. Now, so this slide, even if you want to sleep or what, but just have a look at this slide. This is the basis of my talk for the rest of the day. So here, number one, we are going to distinguish between a screening test and a diagnostic test. I've seen a lot of problems, especially from my registrars. They confuse the two. To say when you are screening someone and when you are diagnosing someone, what are the differences? So, when we are doing a screening, we are saying, let's say we got pregnant women like us in a room, maybe we are 100 or so. For us to diagnose Downs, we need an invasive test, like a chronic fluid sample or amniotic fluid. And those tests, they come with a risk. So we are saying, we cannot offer everyone a jab to diagnose Downs. Let's have a small number where we can put a jab. So this is what the screening test will do. It will just further categorize a small group who are at risk of Downs. Then we offer them a diagnostic test. So these are the screening methods which we offer. So you can see there, like what Dr. Weringer was saying, if your patient comes in at early on, maybe 11 to 13 weeks, you offer them a combined test. The combined test will include a knockout translucent. This one? Okay. No, this is a problem. So it will include a knockout translucent, right? Then it will include some serum test where we do the PAP-A and the beta HCG. And also the maternal age. Then if you don't do the combined test, if she comes at second trimester, you just do your serum test, which are this one, where we do the 4 markers. They are easily available. Or even if she afford, you can do fetal cell-free DNA, the NIPT. Because this test, what they noted was initially, you still remember, people with cancer, they were getting diagnosed using blood at times. Because there's some fragments of DNA which is found in blood. And they thought that the pregnancy, it almost mimic a tumor. I think we have removed a lot of ovarian tumors. And a pregnancy can almost mimic like an ovarian tumor, so that you can get some free fragments of DNA floating in the blood, and you can test that. And the advantage of this, look at this, with a NIPT, even if someone comes at 10 weeks, you can offer it, 11 weeks, you can offer, all the way to 36 weeks. Unlike other screening tests, where you are limited in your window of when to act,
This one you can offer all the way to 37 weeks. You can screen your woman for Downs at 37 weeks with that test. That's the advantage. The other tests, there are limitations because you have to do them at a specific time. Then once you do your screening test, if someone fall into a high risk, which would depend on your cutoff of your figures, then you can offer a diagnostic test. And again, you can see the limitation of our diagnostic tests. They have to be done early, as you've seen on the board there. So are we clear on those tests? Is it clear? Okay, let's move. Now, let's look at maternal age. So I will look at my young boys to say, if you want to marry now at 35 years, what are you doing? Eh? You finished your nice rotations of urology, orthopedic, to meet down. Seriously. So I'm advising the young ladies and the men to say, just do both. Do your SRM rotation and get a baby. There's no need to get to 35 because definitely you are creating other problems. Okay. Now, so in terms of those tests, this is to highlight, because the time is, you might get clients asking you, how long does it take to have these results? So you can see the time frame, almost 2 weeks, you can get your results. And some of them might ask you questions to say, how much are these tests? You know, Zimbabwean women, they want to ask about cost. So I put a slide on cost. So if you want to be screened by maternal age, it's a $0 thing. And the nurse can do that, right? But if you are going to want to be a bit sophisticated and you want your NT, of course, we need to certify that person first, and of course you need to pay $30. And if you are going to have a quad, you just need to pay the laboratory, because it's a biochemical test, it's a $50. And if you are going to do the amnio to continue, of course you need a specialist. So these are the costs in our local setup. Now, one mistake which you shouldn't make is telling the patient that the baby is Downs basing on your markers. You'll be in trouble. Right? Or even not to document your NT. Or maybe we are having twins. Maybe Dr. Ndagura will talk about twins. We cannot use this screening test in terms of twins. Now, so there are other markers besides the one we have said, which we call soft marker. So when a marker is a soft marker, it will mean that even amongst normal individual is there. Which means even in this room, there's someone with a soft marker. But it doesn't matter. But once there are two, now we can diagnose you to say you're at risk of Downs. But if you got one, no worries. Let's go. So this is again our local data, looking at much of referrals, because we want to target the problem. To say, for the patients who come for a detailed scan at fetal medicine, what is the cause of the referral? So the majority, they've seen an increase in knuckle translucent. The other ones, advanced maternal age, or even the abnormal serum screen. This is the devil in the house now. The knuckle translucence, it needs to be done in a standard way. So you need your mid-sagittal, and you need to, at least half of the picture. So this technique you can only acquire if you come to fetal medicine. Don't think of scanning and check for knuckle translucent without passing through the fetal medicine. Because a change even of 1 millimeter can change the risk of the lady from being a low risk to a high risk and can subject that lady to an invasive test. So this test should be done correctly. So let me move. So these ones we have already talked about, which is the NIPT. Now, look at the performance of these tests. So if someone comes in the first trimester, like what Dr. Veninger was saying, and you do a combined test, of course, your detection rate will be high, close to 80, 85, somewhere there. Which means out of 100, let's say babies with Downs, you'll be able to pick 85 of them, which is a good test. But we know our late, they come late. If they come the second trimester, you're going to do the quadruple. Of course, you can see there's now a drop, even in your detection, to almost 75%. But if they can afford, you can offer them an NIPT, which is almost close to 100. It's not 100 though, but it's close to 200 if they can afford. But of course, it's expensive, about 600. Now, these are the detection rates. So if you use maternal age alone, so you can see your detection for your test goes up. Maternal age alone, you are picking 30%. So during our bosses like Dr. Chiwora's time there, they could only pick 30% of the patients with the Downs. But now with an NIPT, you can pick close to 99%. So this is the best test to offer for your clients if they can afford. But if they can't, you can choose which one they can afford. So you would see now people are moving away from just detection rates. They want to look at what we call the positive predictive value. So this figure is to say, if you are saying someone has a risk of Downs, for example, what is the probability that it's really caused by Downs, what you have seen? So it's calculated by using the positive value divided by the negative plus the false positive. So this positive predictive value is much used by scientists now as a way to measure whether the screening test is correct or it's not. Now, so what do you think might be the future in terms of the screenings? So we are thinking that we might integrate AI in assisting ultrasound analysis. What do you think about that? Can AI help us in Can it help? Dr. Masoka? It can. Okay, Dr. Masoka is in agreement. So I think we are going to integrate AI so that next time when we meet, you will see our results. We'll put AI to also help us in interpreting. Right? And also, like we have said, we need precision medicine. What might be the challenges then? Of course, we know our limitation in our region, and even the cost for this test might still be a problem, but of course we look to the ministry to say, can we help us so that we can adopt the AI system? And also, we'll try to train as much as possible on the sonographers. This is an important slide. The problem with fetal medicine is you need to cancel. So there's a pre-test cancelling, which is mandatory, and you explain the limitation, the residual risks of the test which will be done, as well as to explain post. So don't just scan, give the woman a result. You need to explain. So that's why even the consultation fee, I had most of the patients complain to say, why are you charging maybe 180 in private or 200? It's because of this. You need to sit down, need to cancel them. It will take maybe an hour or 30 minutes explaining this risk. Both these are figures which are difficult to explain. Then this slide, I just put it for completeness sake to say, if you are doing it for twins, there might be some challenges, even with an NIPT, if you have twins. Or maybe the mother had cancer, maternal cancer, there's a problem even using an NIPT in those circumstances. Of course, this we have mentioned, the challenges in Zimbabwe, and the future directions we have already mentioned. Now, this slide, the risk of doing a diagnostic test is less than the risk of getting downs. So if a lady comes in and now you see the risk is high, you want to do a diagnostic test, so you also need to explain to her that the risk of losing this baby from miscarriages is lesser than you getting a risk from downs. This is true, but it's a simple illustration to say, where do you go? Maybe you are less than 12 weeks or 14 weeks. You can offer a combined test. If you offer a combined test, someone is low risk, which can be defined, of course, it depends on the sender, 1 in 1,000, routine care. If someone is high risk, you go straight away for a diagnostic test. This is a diagnostic test. But you get some who can fall in between your risks. They are not low, they are not high. Those ones, you can offer them quadruple tests in the second trimester. Right, so let me give a test, because I know students, without a test, they won't learn much. So let's have a scenario there, whereby lady is 39, first visit at 18 weeks, no prior screening. Ultrasound scan, it showed a soft marker, which is mild ventriculomegaly. We like it in MCQ to say mild ventriculomegaly, or you can say severe ventriculomegaly is associated, is a soft marker, and you can get mixed up because of fatigue. So let's say we have this scenario, N1 to take. What do you think should we proceed? Coming for the first time, no prior screening, and on ultrasound scan we just note a mild ventriculomegaly. N1? You want to try? Okay. Yeah, sure. You can get mask.
Okay, thank you. So for this case, and from what we have learned from your presentation, we are going to do counseling of this patient. We are going to talk to her about her risk, the a priori risk. She's already 39 years old, and then we counsel her about that, and she's got that soft markers, and we counsel her about the risk of developing Down syndrome, and she's 18 weeks already. So we could offer her it's already in the second trimester. So if she can afford, would like to do the NIPT, if she affords it. If she cannot, then maybe we'll do the quadruplet test.
Hey, excellent. Clevians. Okay, good. So the soft marker, because it's only 1 or 2, so you can do a quadruple because she's already at 18 weeks, and you can get whether she's in high risk or low risk. Excellent. Thank you. At least I'm doing something great today. Last scenario for the day. This is an anxious mother. You do your nuchal translucent. It's quite high. NT, which is equal to 4 millimeter. Any takers? Nasal bone is present. What should we proceed? Dr. Masok, you are eager to say something.
I wasn't eager, but it's fine. Yeah, okay. So the knockout translucence in this case is high. Ideally, this is a patient that could. I think she's coming at the appropriate age for a combined test. So the knockout translucence is 4. So I think you would also want to combine with the serum biomarkers and then determine a risk. So that's when you can then add a PAP-A and a free beta ACG. And then you combine with the knockout translucent to determine the risk. I'm not sure.
Okay.
I'm just
Any other taker? Last taker? Oh, Dr. Kwaramba. It's okay. You can take.
Thank you, Dr. Chirume, for the scenario. So this patient, so she came in the first trimester for screening of the aneuploid, And the narcotranslucent is high, 4 millimeters. Yes, so she's in the range of doing the combined test after screening. Then I think since the narcotranslucent is high, I think we can also do the chorionic villi sampling.
Okay, clear. So with this one, you go for a diagnostic test straight away, or even if they can afford the non-invasive, which you say they got a higher screening tool, they can go for a non-invasive, but you can go straight away. All right, our time is almost, so let me move fast. So there are some second trimester. It's almost time up. 1 minute, okay. So we know for our late bookers, they don't come at a specific time where you can offer this textbook testing. They just come random. Maybe 28 weeks, 29 weeks, 30 weeks, you name it. Huh? So at that time, you can just do your soft markers. So these are some of the soft markers I will just run through. You can see there. That's what we call an echogenic intracardiac foci. That's what we see it when we scan. In this study, I won't dwell much on it because our time is up, okay? But, or even mild ventriculomegaly, like in that case, this is what we'll be seeing there in the scan. The blackish stuff, this fluid always appear black on a scan. But of course, you need trained eyes. Okay, mild hydronephrosis. These are MCQ for the registrar. Severe hydronephrosis or mild hydronephrosis, they confuse those things, huh? Right? Choroid plexus, that's how they appear on a scan. Okay. Cisterna magna. Now, look at this. So if you do your markers, your soft markers, you get a likelihood ratio which is known. And so how do you use this one to calculate? See here. This is simple maths. Let's say you get an intracardiac echogenic foci like the one we get. You still remember from our maths teacher to say, if you get one intracardiac, you would multiply, your likelihood ratio is 5.3. So you multiply it with the negative ratios of the other. So you would come to say 5.3 times ventriculomegaly is not there, 0.94 times increase in NACA fold is not there, you take the negative likelihood ratio 0.8. Echogenic bowel is not there, 0.9 is a negative likelihood ratio, you put it there. Then you calculate. So this is the figure which you are going to use. So I'll do it when there's more time. And in terms of these findings which we have noted, some would want to do an integrated test where you combine everything, or some might decide to do a sequential step like what Dr. Kwaramba was saying and Dr. Masoka, to say if you find something, you go on to do the other test. It's still okay. And some might even do a contingental screening to say, if you don't find a high risk or low risk, in an intermediate, you do further test. It's another way of doing things. So this you have already talked, because now the lawyers are clever. Please, they are coming after us. So your money, please safeguard it. So don't do all those things, because the lawyers now, the one man, they're hungry, unlike previously. So what is our key take-home message? So we are saying every woman should be screened, whether you are young or you are old. Because what we are noting is even downs in a young patient, they are still there. And the majority are getting pregnant, so that the number might go up. And also, you should know your limits. Know your limits, is even at personal level, as well as for your screening test. You need to know your limits. Right. And the soft markers, we've already talked about them. And for Zimbabwe, we've already talked about the solutions. So what might be the future? We said we need AI, we need to expand our genomics, and also affordable, non-invasive tests. Thank you.